Hello, my name is Elysia Tjong, and I am so grateful for the opportunity to present a case of vaping use-associated lung injury, otherwise known as VALI, that my colleagues and I encountered during one of my rotations. VALI was first characterized in the summer of 2019 with over 2,800 cases reported nationally. We present a case of a young patient who developed acute hypoxic respiratory failure from vaping THC products, particularly one that contained vitamin E acetate. A 27-year-old male with chronic vaping use was brought to the emergency department with shortness of breath and pleuritic chest pain for 2 to 3 weeks. Of note, he was recently diagnosed with pneumonia in the outpatient setting prior to coming to the hospital and was prescribed azithromycin, short course of prednisone, of which he believes was 10 milligrams for 3 to 5 days, and levofloxacin, all of which did not provide any relief. His oxygen saturations on room air initially in the emergency department was 77%, so he was then placed on 5 liters of oxygen by nasal cannula. On physical examination, he appeared uncomfortable and had coarse breath sounds in his bilateral lung fields, but did not have any wheezing or rhonchi. The rest of his physical examination was otherwise unremarkable. Chest X-ray showed bilateral basilar areas of consolidation, and a CT scan of his chest showed some bilateral ground glass opacifications as seen in Figure 1. His laboratories were significant for leukocytosis of 18.1 with left shift and no eosinophilia, and an infectious workup was ordered. He tested negative for COVID during his hospitalization and also tested negative in the outpatient setting. He was then started on ceftriaxone and azithromycin for community-acquired pneumonia coverage and transitioned to broad-spectrum antibiotics, including vancomycin, zosyn, and fluconazole due to continued fever and leukocytosis. When he was admitted to the medicine service, he later told the providers that he chronically used vaping products for the past several years, but only recently started vaping a new THC product with vitamin E acetate for less than 6 months. The patient was later transferred to the ICU due to increasing oxygen requirements, where he was then intubated and underwent bronchoscopy with BAL to evaluate for infectious and inflammatory causes. The BAL showed 150 white blood cell counts with 62% macrophage, 26% lymphocytes, and 12% neutrophils. His BAL cytology was negative for any malignancy, and his finalized cultures were also negative. Interestingly, the macrophages did not have the characteristic lipoid vacuoles seen in lipoid pneumonia or vaping injury. The BAL was not tested for toxicants such as vitamin E acetate, plant oils, or coconut oil. His microbiology was negative for any infections, including Mycobacterium, Legionella, Aspergillus, or Cocci. Blood cultures, sputum culture, and fungal cultures were negative. Because there was little concern for bacterial or fungal infection after his results came back negative, his antibiotics were discontinued. However, his oil red O stain, as seen in Figures 2 and 3, were positive for alveolar macrophages, showing intracellular positivity for lipid. At 60 times magnification, seen in Figure 3, the alveolar macrophages were better visualized, showing the globularity of the lipid. He was discharged on high-dose steroids, which he continued with steroid taper and on supplemental oxygen at 2 liters per minute. He followed up for 4 weeks after discharge and noted improvement with his shortness of breath without any oxygen requirements. With chronic vaping use prior to his hospitalization, our case strongly suggests vaping use-associated lung injury with resolution of symptoms with high-dose steroids and vaping cessation. We wanted to present this case due to the clinical impacts and relevance when it comes to patients who present with acute hypoxic respiratory failure, as it is an important differential diagnosis to include when encountering patients with respiratory symptoms that do not resolve in the outpatient setting. Again, VALI was first identified in 2019, and it is one of the many reasons that can cause patients to have shortness of breath. In this day and age, with the prevalence and high incidences of COVID-19 worldwide, sometimes VALI may be overlooked, especially if a good social history is not obtained. For this patient, though he was vaping products for several years, after obtaining more information, he informed us that he switched to a vaping product that contained vitamin E acetate, as he thought that it would be more healthy given that it has vitamin E noted on the box. It is interesting to note that he developed acute hypoxic respiratory failure requiring hospitalization after using this product for less than 6 months, though it cannot be ruled out that the chronicity of his vaping was not a factor contributing to his symptoms. Due to the prevalence of vaping products today, especially when advertised as an alternative to smoking tobacco, it is imperative that providers are aware of the effects of vaping products and the treatment of VALI in the hospital setting. While there are several cases of Valley that have been described, this case provides an illustrative example of the histopathological finding as identified on oil red O stain and how a patient with chronic vaping use developed Valley after trying a different vaping product, like THC with vitamin E acetate, of less than 6 months. In addition, this case showed how this patient greatly improved with high-dose steroids with steroid taper along with vaping cessation. We would like to thank Dr. Swathi Pathalapattu for her guidance in treatment of this patient on the pulmonology service, as well as Dr. Sachin Chaudhary for his mentorship. Lastly, thank you so much to the Arizona Medical Association for this wonderful opportunity to present a poster.